Hello, everybody. Welcome back. We're on MBME 29-141. These are all original questions. Here we go. A 55-year-old woman with long-standing history of autoimmune hepatitis presents with confusion and irritability. Now, in this question, we have a woman, but in the relevant demographic, I've displayed a man, and that's just to demonstrate how you shouldn't be locked into the female demographic for this particular condition. But I'm going to go ahead and change it to a female now. You can visualize this patient. Her daughter reports the patient was recently treated for cellulitis and hasn't had a bowel movement in 3 days. Vital signs are stable. On exam, she is disoriented and has flapping tremor when asked to extend her arms. Her abdomen is distended. Labs show AST of 86, ALT of 74, ammonia is 118, BUN is at 10, creatinine is 0.9. Which of the following best explains her symptoms? So that flapping tremor is called Asterixis. And the correct answer to this question is hyperammonemia. It's hepatic encephalopathy triggered by constipation and infection, leading to elevated ammonia and CNS toxicity. Asterixis is the key sign, that flapping hand tremor. And that is due to metabolic encephalopathy, which is most often from hyperammonemia. Now you can also see cirrhosis, that's portosystemic shunting and decreasing the ammonia clearance. And if you decrease the ammonia clearance, then some of it can actually cross the blood-brain barrier. And that can cause astrocyte swelling and then cerebral edema. And so the symptoms that you'll see in a patient who has this disorder or who has a lot of ammonia would be confusion, drowsiness, asterixis, stigmata of cirrhosis like jaundice, spider angiomata, as caput medusae. Some things that precipitate this are GI bleeds, infections, hypokalemia, constipation, sedatives. And for treatment, you give them lactulose and rifaximin to reduce the gut flora ammonia production. So if you see that flapping tremor and cirrhosis stigmata and altered mental status, then it's going to be hyperammonemia or hepatic encephalopathy. And that can be the case even if they don't literally give you the ammonia levels. So just to make sure we got this down, a question that you should be able to answer is, what is the pathophysiology of Asterixis in cirrhosis? And that's the buildup of ammonia, right? It's the impaired astrocyte metabolism. And the astrocytes are the glial cells, which are non-neuronal cells that support and protect the neurons in the central nervous system, the brain and the spinal cord. You should also know of some other systemic conditions besides liver failure that can cause Asterixis, and that would be renal failure, uremia, and hypercapnia, which is CO2 retention. So let's talk about the difference between hepatic encephalopathy, and you do need to know this for step one, and uremic encephalopathy or renal failure. So in hepatic, you start with the cirrhosis. That leads to a CO2 necrosis, causing dyspnea, confusion, cyanosis. COPD exacerbation and asterisks can be seen there. But those are the only causes on step one that would lead to asterisks, which is the flapping tremor. And it's actually defined as the sudden brief lapses in sustained posture whenever the hand is flapping whenever the arms and wrists are extended. But I would conceptualize this as metabolic encephalopathy. Encephalopathy is just a fancy way of saying conditions that affect the function of the brain and cause changes in the mental state. Anything that disrupts the brain's normal activity and leads to symptoms like confusion, altered consciousness, and seizures would be classified as an encephalopathy. So that could be infections, viral, like encephalitis, bacterial, like meningitis, or even parasitic infections. It could be trauma, head injury, stroke, tumors, autoimmune disorders, multiple sclerosis, lupus, and even genetics. But encephalopathy most commonly would be confusion, altered mental state, seizures, memory problems, difficulty speaking and understanding language, that sort of thing. Usually when we diagnose it, we do blood tests for infections and metabolic imbalances, and imaging studies due to CT or an MRI of the brain to rule out structural abnormalities. And you can also get an EEG, and that monitors the brain activity and detects seizures. All right, that about wraps it up. Let's go to the next question. 142, we have a 68-year-old woman with a history of chronic insomnia and weight loss. It started on escitalopram after being diagnosed with major depressive disorder. This medication primarily enhances the serotonergic signaling from neurons located at which structure? Well, it's serotonin, the Ralph nuclei. So SSRIs inhibit the reuptake of serotonin. We all know this. And the Ralph nuclei is the primary search nuclei. And so you should really pick this with anything related to serotonin. Now, you have cell bodies in the midline brainstem reticular formation, like the midbrain, the pons, and the medulla. And the neurons here convert L-tryptophan to serotonin, 5-HT. And they project widely to the cortex, the hippocampus, the hypothalamus, and the spinal cord. So fluoxetine, sertraline, paroxetine, those guys all block the serotonin transporter. And so you increase the serotonin in the synaptic cleft. That obviously increases your sleep, your appetite regulation. So serotonin is synthesized in the RAF nuclei. So here I've updated the patient demographic for this question. Here's some trap answers and why they're wrong. VTA is dopaminergic, involved in the reward. We had a question about that on our last set of 10. Hypothalamus regulates homeostasis, but not the source of serotonin. The locus coeruleus produces norepinephrine. Nucleus bacillus is cholinergic, so it's important in Alzheimer's. This is just depression. You should know the mechanism of serotonin causing 5-HT to stay longer in the cleft. L-tryptophan is a metabolic precursor for serotonin synthesis. Okay, for the next question, it could be a man or a woman. Here we have a 41-year-old man with chronic tension-type headaches has started on a new medication for prophylaxis. 1 week later, he presents with abdominal bloating, constipation, and difficulty urinating. Vitals are stable. He has dry mucous membranes and decreased bowel sounds on exam. Neurologic exam is normal. Which of the following neurotransmitter effects is most likely responsible for his current symptoms? So here's our patient demographic. Though it could be a female. And our answer is D, muscarinic acetylcholine receptor blockade. So they have constipation and dry mouth and urinary retention. Those are anticholinergic symptoms. And this could be because they use the tricyclic antidepressant to stop the headache. TCAs block muscarinic receptors. Now, this is really interesting because the question stem is going to give you constipation and they're going to give you urinary retention and they started a new antidepressant, or they'll have you infer the antidepressant. Feeling blue, started on something new. Constipation, urinary retention. Okay, so all these things are happening at once, and you have to know the mechanism of action because they're going to ask like which neurotransmitter blockade is actually causing this. And so tricyclic antidepressants, these are known as TCAs, they are less selective, and so they block a lot of things. They block 5-HT and norepinephrine uptake, and that's the therapeutic part of it, right? They're muscarinic acetylcholine receptor blockers, and that is going to contribute to the side effect profile. You typically don't want those, but that's how they're going to test you. Because of that constipation, that urinary stuff is because of that muscarinic acetylcholine receptor stuff. And it's because the TCAs, which were taken for the depression. So the depression was treated with TCAs. The TCAs caused, through the blocking of muscarinic stuff, the constipation and the urinary symptoms. That's the way these problems work. And that's why I think they're kind of interesting. They're good questions. Now, they also can block the histamine. These are H1 receptors, and that causes sedation and weight gain. They block alpha-1 adrenergics. They block the muscarinics, and that causes the anticholinergic effects, the urinary retention, constipation, the dry mouth. And they're going to try to get you, they always, anytime you see a question about TCAs, they'll try to trick you in all sorts of ways. One of them that they love asking is dopamine. And dopamine is blocked by antipsychotics, causing extrapyramidal symptoms. You might see some hyperprolactinemia, but not constipation and urinary problems. So it's not going to be dopamine associated. And let's look at the answers here. So dopamine antagonism would be antipsychotics, not constipation. Alpha-1 blockade causes orthostatic hypotension. H1 antagonism, sedation, weight gain, and GABA agonism would be benzos and barbs, sedation but not anticholinergic effects. So yeah, antidepressants can make you stop pooping, at least TCAs. All right, so those are the buzzwords: dry mouth, urinary retention, constipation, hot as a hair, dry as a bone, blind as a bat, red as a beet, mad as a hatter, anticholinergic, toxidrome pneumonic. Elderly patient, they're super sensitive to it. TCAs, the triptylines for MDD, also for migraine prophylaxis, and the blocking of the H1 receptors can cause that sedation, and the alpha-1 adrenergic blockade causes orthostatic hypotension. There's the pathophys that we kind of talked about. It is blocking the muscarinic receptors, and so you have less contraction of the bladder, less peristalsis, and that would be urinary retention and constipation, respectively. Blockage of the salivary glands, that's the dry mouth, and the central effects of delirium and confusion in the elderly. I think we covered that question pretty thoroughly. Okay, so the next question, we have a 28-year-old Olympic sprinter who has undergone muscle performance testing. During the experiment, her vastus lateralis is electrically stimulated to contract under isotonic conditions at varying loads. Researchers observed the maximal shortening velocity of the muscle does not increase beyond a certain point, despite higher frequencies of stimulation and sufficient ATP availability. What determines the maximal velocity of muscle fiber shortening under these conditions? The answer is myosin ATPase activity. Now here I actually want to go up to the buzzwords first. Cross-bridge cycling. You know about the actin and the myosin heads. ATP hydrolysis is required to reset the myosin, and isotonic contraction is when the muscle shortens under constant tension. And the rate-limiting step here is how fast myosin can detach and recock and reattach. It's biochemical, it's not electrical. Type 2 is the fast fibers, higher myosin ATPase activity. Thyroid hormone increases expression of the fast myosin heavy chains. And so faster ATPase causes faster detachment and quicker shortening. And here's the motor neuron fires, acetylcholine is released into the neuromuscular junction, then it depolarizes. Calcium is released, exposes the actin. Myosin binds the actin, power stroke, sarcomere shortens. ATP binds myosin, detaches from actin, hydrolyzed, restocks, and so it's the rate of the shortening that affects the rate of the cycle. Now, isotonic contraction is when the muscle generates a constant tension while the length is changing. That's isotonic contraction. There's concentric, that's muscle shortening while contracting, and there's eccentric, that's muscle lengthening under the tension. The speed of shortening is determined by how fast the cross bridges cycle between actin and myosin. I remember they tested me on the actin-myosin binding. In one of my biology classes at Harvard, we had to list all of the steps of the cycle, and I think that's overkill. But I would say one of the most important things to know is that first you have the myosin and the ADP, the binding of the actin, the cross bridge formation, and then ATP binds myosin, and that's the detachment phase. And then you have ATP hydrolysis. And that's where the myosin is recocked and the cycle will repeat. So faster ATP binding and hydrolysis means you have faster myosin cycling, which means you have faster sarcomere shortening. And so the rate of the cross-bridge turnover determines the max velocity of the isotonic contraction. Wow, we got in the weeds there. Let's make this super simple. Isotonic contraction are the changes in length under constant load. The speed is determined by how fast the cycle happens. Faster cycle, faster shortening. Okay, 3 things we need to know. What determines max velocity? That's the rate of the cycling, the ATP turnover. And in smooth muscle, why is contraction slower? That's because the cycling is slower, which allows for sustained tone. Okay, and if any of you guys are like, oh my gosh, what's going on? Then look at these buzzwords right here. And you see this right here, lifting a dumbbell. That's where the muscle shortens while you're holding a constant weight. That would be isotonic contraction. The muscle is shortening while holding a constant weight. What makes the muscle shorten? The myosin pulls the actin. That causes the sarcomere to shorten, and then the muscle shortens. What controls the speed of that, though? Well, the speed is how fast the myosin head can grab the actin, pull and do the power stroke, let go, where the ATP binds, and then reset and try again. That cycle is called the cross-bridge cycle. And so faster recycling means faster shortening. And they can try to trip you up in all sorts of ways. They could ask about the action potential, amplitude, the frequency. Well, the amplitude is just all or nothing, right? It doesn't change how fast the contraction happens. The frequency, more frequency, would just mean stronger force, not faster shortening. And it actually does not involve your sodium, potassium ATPase, because that's just involved in the maintenance of the ion balance, not the contraction speed itself. So the big takeaway here is the maximum rate of muscle shortening depends on how fast the myosin heads cycle cross bridges with actin, and that's powered by ATP. So if you choose ATP on that, you'll be right. The force is how many cross bridges are working, and the speed is how fast the cross bridge cycles. All right, this could be a boy or a girl. Here we have a 6-month-old girl is evaluated for macrocephaly and delayed motor milestones. Her parents report she's unable to sit, unsupported, and has poor head control. Physical exam shows hypotonia and increased head circumference. Neurologic exam reveals downward gaze and increased limb tone. MRI of the brain demonstrates a large fluid-filled cavity in the place of the cerebellar vermis, enlargement of the fourth ventricle, elevation of the tentorium. Which of the following embryological structures is most likely implicated in this patient's condition? And we have all these classic answers. So we unfortunately have to know the step 1 embryology chart for the brain vesicles and the adult derivatives. Now the diencephalon is derived from the prosencephalon. The adult structure that is formed is the thalamus and the hypothalamus and the retina. And this is from the third ventricle. The mesencephalon is derived from the mesencephalon. And the adult structure that's formed would be the midbrain. And you should associate the mesencephalon with the cerebral aqueduct. The metencephalon is derived from rhombencephalon, and that gives rise to the pons and the cerebellum, and that's the upper fourth. And the telencephalon is derived from the prosencephalon, and that forms the cerebral hemispheres, basal ganglia, and it's associated with the lateral ventricles. Okay, so the metencephalon would be associated with your pons, cerebellum, fourth ventricle, that's Dandy Walker. The mesencephalon, or the midbrain, that'd be associated with cranial nerve 3, 4 nuclei, and the cerebral aqueduct obstruction, so hydrocephalus. The diencephalon would be the thalamus, the hypothalamus, and the retina. And there you'd see like craniopharyngioma, compressing the hypothalamus. And the telencephalon, defects in the telencephalon would cause holoprosencephaly. And so if the question mentions the cerebellum and the fourth ventricle, then you should think of the metacephalon. And if it mentions the cerebral hemispheres and the lateral ventricles, then you should think of the telencephalon. L for lateral. Telencephalon, lateral ventricles. Telencephalon, lateral ventricles. Midbrain, M for midbrain. And so here it's the cerebellum and the fourth ventricle that we're talking about. And so it is the metencephalon. This is Dandy Walker malformation, failed development of the cerebellar vermis. They're the trap answers and why they're wrong. And so the hindbrain, specifically the metencephalon, is supposed to form the cerebellum and the fourth ventricle, but it's not here. All right, next we have a 6-year-old boy presenting with evaluation due to rapidly growing nodular lesions on his scalp and cheeks. His parents mentioned that he's allergic to the sun, reminds me of bench warmers, and had frequent blistering sunburns after brief outdoor play during infancy. All right, this could be a female as well, but I'm going to go ahead and give you both. So I'll generate a photo of this patient over here. There we go. Which of the following DNA processes is most likely defective in this patient? Blistering sunburns. All right, this is Xeroderma pigmentosum. How do I know? Early onset, photosensitivity, and increased cancer risk. You'll see recurrent blistering, severe sunburns after sun exposure. That's why they said he's allergic to the sun. Also freckling, dry, atrophic skin. And the mechanism for this is kind of one you just memorized. In fact, one of the earliest videos of the 790 I have on my channel was about nucleotide excision repair. Now, how this works, I'll go over to 146, is it starts with the sun, right? The sun has UV light, and that forms pyridamine, thymidine, dimers. And nucleotide excision repair removes those. So it's doing a great job removing those. And the mechanism is endonuclease cuts out the damaged DNA segment, DNA polymerase fills in that gap and DNA ligase seals the strand. That's the mechanism by which nucleotide excision repair deals with the formation of pyridamine dimers by UV light. But if you have a defect there, then your pyridamine dimers will persist and you have mutations and skin cancer. The sun is indeed a deadly laser. And so this occurs in the G1 phase of the cell cycle, and you see skin cancer in children. I would have designed it differently, but it was not up to me. And they'll try to get you with different answer choices. For instance, base excision repair. What's that all about? Well, that's just fixing the damaged bases, right? The deamination of cytosine to uracil, not UV dimers. They could also get you with mismatch repair. That fixes the DNA replication errors, and anytime you see mismatch repair, you should immediately be thinking of Lynch syndrome. ATM kinase, ataxia telangiectasia. You'll see recurrent infections and cerebellar atrophy. Exonuclease proofreading, that'd be errors in DNA replication, not the UV damage. Base excision would be from oxidative and alkylated base damage. Mismatch repair, microsatellite instability, think Lynch. So if you see on test day a kid who's not old enough to even ride a bike and he already has skin cancer, then what's actually happening is Xeroderma pigmentosum. There's the pathophys that I kind of spelled out earlier. You accumulate those oncogenes and the tumor suppressor mutations because that NER pathway does not identify the bulky lesions and remove them via endonuclease. So you could definitely see endonuclease as an option here. In fact, I believe in the UWorld Bank, there is a question where the answer is endonucleases, and it's Xeroderma pigmentosum. You can see why. That's how they ask about this condition. UV light exposure, how do you get rid of them? Endonuclease activity, but it's defective here, so you get skin cancer in a young kiddo. All right, next question. Okay, here there is a 69-year-old man with diabetes. It could be a female as well, probably a similar age though. Undergoing emergent percutaneous coronary intervention for an inferior ST elevation myocardial infarction. Coronary angiography reveals a left dominant circulation and critical stenosis in the vessel perfusing the diaphragmatic surface of the heart and atrioventricular node. They plan to place a stent. Through which vessel must the catheter pass in order to reach the affected vessel? All right, I'm going to update the patient demographic so you can see this particular patient that we're talking about. Here he is. Nice guy. All right, now this question is easy to miss unless you have all of the blood supply of the heart down pat. We have to go from the left coronary artery to the posterior descending. Now, the way to think about this for exams is a right dominant heart is different from a left dominant heart. And in right dominant, the RCA gives rise to the PDA. But in a left dominant heart, the left circumflex gives rise to the PDA. That's the difference. And if it's codominant, then both the RCA and the left circumflex contribute. So there's a patient with a left dominant circulation, and so the catheter has to be put into the circumflex, and then it goes to the PDA. It's kind of like a memorization thing. Now, if it's right dominant, then sure, it's just the right coronary artery. That's 85% of the cases. The RCA supplies the PDA and the AV node. But in left dominant, the left circumflex supplies the PDA and the AV node. Now, I want to make this simple for every single heart supply question that you ever get in the future. Let's name the arteries, for instance. Here we have the anterior interventricular artery, LAD, and that supplies the anterior left ventricle wall, the anterior 2/3 of the interventricular septum. So left coronary gives rise to LAD, and it supplies the anterior 2/3 of the interventricular septum. Left coronary also gives rise to the left circumflex. That supplies the lateral and the posterior left ventricular wall. Now, the aorta gives rise to the right coronary artery. That would involve the inferior wall of the left ventricle. And then this question is asking about the tough case with our PDA, posterior descending. And that's tricky because in right dominant individuals, it's the RCA, but in left dominant individuals, it's the left circumflex. Okay, so the PDA is the weird one. And the way to think about this is like public display of affection. I just think it's right. You're right if you think it's right, PDA. And you're left alone if you circumvent the PDA. Whatever gets you there. But most of the time, the PDA origin comes from the right coronary artery. Most of the time. It's like in 85% of people. But they always have to ask about the 5 or the 8% of people from which it comes from the left circumflex. And that's the left dominant heart. And sometimes it's codominant as well. So left dominant, you really got to watch out. And if it's left dominant, it's probably going to be the circumflex. That's how I think about it. All right. In our next question, we have a 6-year-old boy brought to the clinic with recurrent joint swelling and behavioral issue. He bites. Oh, that's sad. Self-mutilation. All right, so that immediately cues us into C. This is Lesch-Nyhan syndrome. You treat with allopurinol and febuxostat. That's the decreasing of the xanthine oxidase activity. This is one of the first conditions that I covered in I believe it's MBME 26. Question 1. Yeah, this is like one of the saddest little conditions. It's intellectual disabilities that are seen since infancy. You know, the biting of the lip and the fingers. You have severe gout as well. Uric acid crystals, hematuria, and flank pain. It's an X-linked inheritance pattern. You should watch the MBME 26 recap video where I covered topics like this. But HGPRT is the key enzyme in the purine salvage pathway and its function to turn into GMP. Definitely go watch that video if you want a more in-depth explanation, but without HGPRT, you cannot salvage purines. And then they get shunted into degradation. And then that increases the uric acid, and that leads to gout, kidney stones, and then the neuro symptoms. You treat it with allopurinol and febuxostat. That blocks the xanthine oxidase to decrease the uric acid production. But it's Lesch-Nyhan syndrome is absent HGPRT. A way you can remember this one is, it's a really sad symptom that they have, the self-biting and stuff. And you could think that they have an absent parent. And then I like to think of HGPRT. The PRT kind of sounds like parent, absent parent. Helps me remember that Lesch-Nyhan syndrome with the poor behavior in the child, the neurosymptoms caused by the increase of that uric acid is because of like absent parent behavior. Whatever helps. Increasing uric acid, intellectual disability, self-mutilation, aggression, gout, and chorioathetosis. And that's just a movement disorder that's marked by a combination of chorea with the rapid, jerky, and involuntary movements, and athetosis, which involves the slow wiring and twisty movements. All right, so there's the explanation. Adenosine deaminase is SCID. Orotate phosphoryl transferase is megaloblastic anemia unresponsive to B12. Xanthine oxidase is treated with allopurinol. Carbamyl phosphate synthetase 2 is a de novo pyridamine synthesis defect. This is a purine salvage pathway. And they could try to confuse you. They could give you glycine pathways, which would cause encephalopathy if it were defective, or they could give you serine problems, or even xanthine oxidase. But xanthine oxidase converts xanthine to uric acid, and so deficiency causes decreased uric acid and increased xanthine stones, which is the opposite problem. There's not a deficiency in xanthine oxidase. It's quite the opposite, my friend. So, yep, gout, aggression, retardation, tonic movements, dystonia. That's what you should look out for. HGPRT. All right, so here, this could be a man or a woman. So I'll go ahead and give you a demographic of both. First, we'll start with the woman, and then we'll move over to what it might look like on a man. So a 29-year-old man comes to a clinic due to recurrent clusters of painful blisters on the left side of his face. By the way, let me know if you'd like both of the patient demographics or if you'd just prefer the one relevant to the question. I think it's good to expand your horizons so you don't just lock in on one patient demographic for cold sores, for instance. But I digress. Would love to hear feedback. 29-year-old man, he's got the blisters as you can see there. Similar issues in college triggered by stress. Group vesicles of arithmetic base along the maxillary distribution. Okay, so it follows a distribution. What enabled the virus to establish the latency? It's retrograde axon transport. All right, so you might see painful blisters on the lips and it's recurrent and has like maybe a 10-year history. That's going to be herpes. It's HSV1, usually. HSV2 is also possible. And they love this question. How does HSV get from the skin to the sensory ganglion for the latency? So the way that this works is HSV infects the epithelial cells of the mucocutaneous sites. So it's going to be the lips. And the virus then hijacks the neuronal microtubules and it moves retrograde. That means backward or toward the cell body into the trigeminal ganglion for oral lesions. And there it establishes latency. And it's basically a fancy way of saying you're hiding. It's like a game of hide and seek in the immune system. And on reactivation, HSV then travels anterograde, which is forward toward the axon terminal. Retrograde backward toward the cell body. Grade is toward that terminal. I'll say it again. Retrograde backward toward the body. Like retro arcade games, they're old times, so you go backward toward the body, the opposite way of where the synapse would travel. And then they can go anterograde afterwards, and they go forward toward the axon terminal, back to the skin, causing the vesicles. That's usually what they like to ask about this. Now, let's look at some of these answer choices. This is pretty much what I said here in the explanation, more or less. It does also mention that there's movement that uses the dynein motor protein to move against the polarity toward the neuronal soma. But anterograde is reactivation. Exocytosis would be the releasing of viral particles, not how they move within neurons. Protein translation happens inside the affected cells. Neurotransmitter diffusion is irrelevant. HSV does not use synapses and neurotransmitters to spread. Some key terms here are action potential, which is electrical signaling, and that's not used by viruses for transport. Protein synthesis, which is needed to replicate the virus, but it's not the way that latency is established. And so maybe 3 questions that I would ask to make sure that you'd have this topic down pat would be 1, which process establishes the HSV latency? And that's retrograde axon transport. 2, which process reactivates it? That's anterograde axon transport. And then 3, which antiviral is a guanosine analog that blocks viral DNA polymerase? And that's acyclovir. Also valcyclovir or famiciclovir. The cyclovirs. These are antivirals. They are guanosine analogs that block viral DNA polymerase. And I actually have seen this on a test question before, that the mechanism for acyclovir, valcyclovir, and famiciclovir is that they are guanosine analogs. And they are activated by viral thymidine kinase. They are phosphorylated, and then you inhibit the viral DNA polymerase. So there's a chain termination. It's used in HSV1, 2, VZV as well, so chickenpox, It's not great for CMV because it's a poor substrate for CMV's kinase. Ganciclovir is a guanoside analog for CMV, so ganciclovir is a little bit better for CM cytomegalovirus. And ribavirin is a guanosine analog for RSV and HCV. But acyclovir is activated, so think acyclovir. Associate this with HSV1 and 2, but acyclovir for activated by viral kinase, and it's used for all herpes. AAA, all herpes activated by viral kinase, HSV or VZV, and VZV as well. Now, I have to tell you one more thing because you're going to get tested on this. Acyclovir, valacyclovir, famciclovir, these mechanisms are guanosine analogs. We talked about this. Ganciclovir is a guanosine analog that inhibits viral DNA polymerase. And then foscarnet is a pyrophosphate analog that directly inhibits viral DNA. There's no activation required for foscarnet. Cidofovir requires only a host kinase, not the viral kinase. So just make sure you know the difference there. This guy right here is going to be seen with CMV retinitis. That's like its use. The use for acyclovir, valcyclovir, and famciclovir is going to be HSV1 and VZV. The use for ganciclovir is CMV. And you can remember that because G kind of looks like a C, ganciclovir. It requires the viral kinase, and thymidine kinase is required for acyclovir. But foscarnet does not need kinase activation, and cidofovir requires only the host kinase. All right, this next question is super crazy easy, so I'm not going to dwell on it a lot. It's just the difference between precision and accuracy. The answer is method A is more precise than B, because A has less coefficient of variation, and B has this, and that's how you know it's precision. So precision is another way of saying consistency. Look at these dots, they're consistently in the same spot, but they're not accurate because they're not in the middle. Look at this dot, it's accurate, but then it's maybe not precise because all of the other ones are randomly placed. All right, so precision is consistency, and the coefficient of variation quantifies how consistent measurements are relative to the mean. And so the lower CV means greater precision. Okay, super easy question, and we have done the first 150. If you found this helpful, please like and subscribe. If not, just let me know how I can improve. I'm always happy to continue improving this channel. If you guys need tutoring from a Harvard tutor, just let me know. That's a good way to guarantee that you'll pass this exam. We'll see you guys in the next video.